How are you looking after your vulva garden? As we move through menopause, our vulvas become hormonally sensitive and experience a number of changes which lead to dryness, pain, discomfort that not only affect our sexual health, but our overall health and longevity. And like any garden, our vulvas require nutrients, hydration, and oxygen or blood flow. My guest today is going to talk us through how to prioritize our vulvar health so our garden can continue to flourish well into our hundreds. Welcome to Pleasure in the Pause, a podcast dedicated to inspiring midlife women to feel more connected to their bodies, pleasure, and power through perimenopause, menopause, and beyond. I am your host, Gabriella Espinosa, midlife and sexual wellness coach, and I am so happy that you are here. Today, I have the pleasure of speaking to Dr. Maria Uloko, a trailblazing urologist revolutionizing the field of comprehensive sexual health. Her expertise spans across an impressive range of treatments, addressing the needs of all genders, from tackling challenging conditions like vulvar arousal dysfunction and sexual pain to pioneering low libido solutions, menopause management, and hormone replacement therapy. She's a fervent believer that research equals advocacy and is dedicating her career to bridging gaps in care and knowledge, particularly in underexplored areas like vulvar health through her new venture, Vulva AI, revolutionizing vulvar health for all. Welcome, Dr. Uloko.
Hello. Hi. Thank you so much for having me.
I am so excited that you are joining me for this deep dive conversation on prioritizing vulval health for midlife women. And I know you have this very unique lens as a urologist and also believe that a healthy vulva makes a healthy bladder. So I'm looking forward to having you connect those dots for us. But before we go there, I'm always so curious to know when I meet experts like yourself, were you always this comfortable talking about sexuality, vulvas, and how did you land in this unique space of sexual health?
Yeah, so that's a great question. Thank you so much for asking. No, so it's interesting. I grew up in a really patriarchal family. I'm Nigerian, and if you know Nigerians, we're very loud, verbose, and it's not a culture, at least in my house, that was sex was celebrated. It was actually very shamed. My parents are also deeply religious. And so growing up with that, sex wasn't something that we talked about. It was something that was so super shameful and really, especially female sexuality, because I have three brothers. I'm the only girl, and we were treated very differently. And I didn't like that. And I think early on that really got me into this headspace of, I'm being treated differently because of my gender. And so what else are my parents wrong about? And so it led me down this road of, I think I've always been that kid that don't touch that, and then I'll be the one that wants to just go and touch it just to see what happens. And so I think because my parents were so anti-sex, and knowing who I am and knowing kind of the way that my brain works, it's like, okay, well, if they're so afraid of it, now I want to know all about it. I've always been gravitated towards sex because it was something that I wasn't supposed to do or know or see, while also having like a healthy fear of it because of that. And so a lot of this work I have done personally is unpacking a lot of that shame, a lot of that cultural narrative, a lot of that religious shame and religious burden around sex and sexuality. And I think there's an easy way for me to do that was through science, right? It's like I'm still the good Nigerian girl because I'm a scientist and I'm a doctor, but I do sex. So it was my bargain in life. But I've done a lot of work personally to get really comfortable with sex and sexuality on my own lens because I realized that as someone that's my job is to help others get comfortable with their bodies, their sexuality, their sexual health. And if I'm not comfortable having these conversations, saying these words and getting really into the nitty-gritty of it, I won't make them comfortable. So I take my view on sex and sexual health and practices as part of my job of anything I learn around sex and sexuality actually helps me become a better doctor. So it's a really fun incentive.
Thank you so much for unsilencing, unmuting that shame around something that's so fundamental to our overall health and well-being. And I think, yeah, a lot of what you say resonates with me as someone who grew up in a Latin American household. My parents immigrated to the US and there was so much silence around that. And I think we spoke
Hmm.
before this conversation that it also led to my own silencing around this
Yeah.
topic, and as it does to everyone. And we're living in a culture where this topic has been silenced and shamed. And yet, you also, like I was, although it was silenced and shame, you realize being in this country that it's all around us. Sexuality is all around
Yes.
us, right? It's on the
Yes.
billboards and movies and TV. It's everywhere. And so you grew up with like, hey, wait, this just doesn't make sense. My parents are
Yes.
telling me this, but I am seeing this. My American girlfriends are talking about this, and it just
Yeah.
something needs to shift here. Something is not right.
Yes, 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 it is everywhere. And I think that's actually that speaks to a bigger, larger narrative of sex is everywhere, and yet getting good information, evidence-based, caring, compassionate information around sex is actually really hard to find. You have to
Mhm.
go and search for it. What I've realized is that that lack of education and that lack of knowledge and that lack of openness actually leads to a lot of sexual dysfunction in a lot of people.
Mm.
And so that is, I'm on a mission to start having these conversations, to start bringing knowledge and facts to a lot of sexual health conversations because I'm realizing we're doing a lot of us are doing it wrong. And then they
Mm.
show up in my office and I'm like, oh, I had one woman, there's something called squirting, right? Which is, the female ejaculation. And it's a whole genre of porn. It's a lot of people want that. It's considered like, a really, really cool thing to do if you can do it. Um, and she had no idea. She thought it was so embarrassing. Because she was so embarrassed by it, she didn't even want to have orgasms. And so she came to my clinic for orgasm dysfunction. And I had to educate her on like, no, you're not having an orgasm dysfunction. Like you're having some of the best orgasms that people are fighting for. And so we did some extensive education on squirting and what that means and what the actual biology and the physiology of it is. And when I gave her that, you could just literally see the shackles coming off of her. And when she came back to see me in clinic, she's like, Dr. Uloko, I'm having so many orgasms. And I was like, I love this. I love this. That was so easy. Because orgasm dysfunction is really challenging to treat. And
Mm.
all I had to do was tell her, like, no, you're doing it great. You're actually doing it so well. And so, yeah, these conversations and seeing things like this over and over and over again made me realize like how deeply it is also part of my job and part of my mission to make sure that no one is coming to my office for things that we could have easily Googled or learned, right? And so that's what I want to bring to people is taking away the shame, taking away the stigma, and bringing in just pure science and fun in a shame-free way.
Yeah, and I also noticed that celebratory tone with which were approaching that patient of yours. Yeah, and it's here to celebrate too. Sexuality is something we
Yes.
must celebrate and embrace. Listening to you, I know that you're a urologist, so you specialize, and maybe
Mhm.
you can correct me, you specialize in bladder and urinary function, which is why you know so much about squirting, because it is part of that urinary function. Um, but and you've also become a huge advocate for vulval health. And I know you see these two symptoms as so interconnected. In reading
Mhm.
a lot of what you've written and hearing you speak, that's something that I didn't realize that these two systems, urinary and vulval health, are so interconnected. And you were telling me that you didn't know that
Yeah.
when you started in medicine. So when was your aha moment when you realized you needed
Mm.
to focus on vulval health and bladder urinary health as together because they're so interconnected for us?
They're so interconnected. And I would say I've been in medicine since I was 17 years old. Started med school at 17. And and I'm 32 now, so 15 years. And I would say it wasn't until 2020 that and that was after I did so 2020 is when I started my fellowship in comprehensive sexual health, which means that I take care of the surgical and medical management of sexual dysfunction of all genders. So that was the first time that I'm actually getting training about what the vulva is, how it works, why it should be healthy, actually learning the parts and the hormones. And these are diseases that we commonly see. And I had gone through medical school, surgical training, urology training, and we are in the vulva, the urethra, which is the hole that you pee out of, is right smack dab there. And in all of our training, we didn't learn any of those other structures. And I was kind of like, wow, this is crazy. I mean, the phrase, you don't know what you don't know, really slapped me in the face during my fellowship. I was like, I thought, what more could I learn? I'm doing this 1 year sexual health fellowship. Kind of just wanted to live in San Diego. And I was like, I also love the idea of being able to provide sexual health for everyone. But I didn't anticipate that I would learn this much. I thought I would just fine tune something. And in that year, I was like, I had learned way more than I learned in my previous 13 years in residency and medical school. And so when I then started my clinical practice, again, now knowing all this vulvar health knowledge, and when I started at the first clinic, a vulvar health clinic run by a urologist that openly took insurance, I also ended up inheriting the UTI clinic. And for most urologists, recurrent UTIs is like we don't love it. And the reason we don't love it, it's not because the patients, it's because we haven't figured out great ways to solve it. So it's just really challenging to watch people suffer and us not have really great tools to prevent that. And so it was kind of this package deal that, like, okay, if you were going to open this clinic, you're going to have to take over the UTI clinic. And I was like, you know what? Why not? At this point in time, I'm celebrating the idea that I have this so much more knowledge, so much more tools in my toolkit. So I was like, maybe I could tackle UTI. And so when I started seeing patients, my pelvic pain patients, my sexual health patients, and my UTI patients were all telling me the same thing. They're all saying the same symptoms. And I was like, wait a second, hold up. And so I created this protocol where I started evaluating my UTI patients through the lens of not only a urologist, but also the vulvar specialist. And
Mm.
in that experience, I roughly over 2 years saw about 300 patients just for UTIs alone. And 88% of the people that fell into the criteria for this protocol actually had a vulvar condition caused by a lack of hormones to the tissue and not a real UTI. The symptoms mimic each other. And because the symptoms mimic each other, and because most doctors aren't trained on the vulva, they keep getting antibiotics. The reason why
Mm.
you keep getting antibiotics and it's not working is because we're treating the wrong thing. So 88% of people that came into my clinic for what they thought were UTIs, recurrent and chronic UTIs, were actually a vulvar condition. I treated their vulvas, I changed their bladders, I changed their lives. That to me was the most radical, amazing thing. Like, I am probably one of the few urologists that's like, I love UTIs. I love chronic pelvic pain because I now know the science. I understand the tissue. I understand the science behind the tissue. And because of that, I'm able to better treat these patients. And it is one of my favorite things to do. I love being able to give people their life back when they've been told you're never going to get better.
That's an amazing story. Yeah. And I've heard so many sad stories from women in my own family who are suffering from those chronic UTIs and just being treated
Hmm.
repeatedly by antibiotics. I want to go there in a minute, but I wanted to ask you, you said women were coming in with the same symptoms. What were those symptoms?
Yeah, so, classic UTI symptoms are pain with urination, burning with urination, urinary urgency, I gotta go, I gotta go, I gotta go, urinary frequency, I'm going a lot. And some people will also have like lower abdominal cramping. So those are kind of like the classic signs of a UTI. And then as it
UTI,
progresses,
sorry. So UTI, I don't know if we've spelled it out, is a urinary tract
your
infection,
tract
right?
infection, yeah,
Mhm.
yeah, yeah. So bladder infection, and then as it potentially can progress, you can also get a fevers, chills, pain in the side where your kidneys are. Those are like bigger, more dangerous signs of a UTI. But kind of the classic beginning signs of a UTI also mimic a condition called hormonally mediated vestibulodynia. So HMV, which just means my vulva is inflamed because of low hormones. I always tell people your vulva is a garden.
Mhm.
Without sunlight and water, your vulva cannot thrive. And the things that are the sunlight and water for your vulva are hormones. Without hormones, and that is estrogen and testosterone, your vulva cannot thrive. And then what happens to your vulva is that it literally starts undergoing all of these changes. It starts becoming red, raw, inflamed. The skin becomes more brittle. The flora, the healthy bacteria that protects you against infections all change. So now that good bacteria dies out, the bad bacteria can come out and play. And so all of these changes start to happen, and you then get the symptoms of urgency, frequency, burning, pain with urination, because hormonally mediated vestibulodynia, the vestibule is a specific part of the vulva that's actually bladder tissue on the outside of the body. So they mimic each other. A bladder infection is inflamed bladder tissue caused by a bacteria or a virus. A HMV is inflammation of the bladder tissue, but caused by hormones. So, because most doctors don't know this, instead of giving the hormones, which could potentially solve and break this cycle, they just keep getting antibiotics. And so, it's also this tricky thing because a lot of people, when they start getting these symptoms, they'll go to the urgent care, their primary care provider, some person to go get a UA, a urine analysis. So they pee in a cup, and someone looks at that cup under a microscope to see if there's signs of infection. But actually, all a urine analysis does is tells you if there's signs of inflammation. And so, as we just said, a bladder infection is inflammation, HMV is inflammation. So, a lot of people on their UAs, they're actually having positive UAs. So, it also then, that's where we get that diagnostic conundrum of wait,
Mhm.
my UA is also positive for an infection and HMV, but doctors only know infections. So that's why people keep getting antibiotics when in actuality, a lot more people should be getting low dose vaginal hormones instead of antibiotics because you don't actually have a real infection. You have inflammation and it's triggered, especially my post sex people. If you are immediately getting infections after sex over and over and over again, it's
Mhm.
most likely not your bladder. It's most likely your vulva. And those are some of my favorite patients to treat because we treat the vulva, they're done having infections and back to having a healthy sex life.
Wow. Why don't more doctors know this? Please tell
Well,
me.
because yeah, because this is brand new research. So
Oh,
this research
really?
was presented, yeah, so this research was presented at the AUA 2023, and we're finishing up the manuscript now. But the interesting thing is that it's so funny. Why is this not known? So I think it's because the pelvis, female pelvis, has a bladder, it has a vagina, and it has a rectum, and it has muscles. But we've divided the female pelvis into three different specialties: urologists,
Mhm.
gynecologists, colorectal surgeons. And for men, they also have a pelvis, and it's just urology and colorectal. So we own the entirety of the male pelvis for the most part as urologists. For women, it's interesting because as a urologist, all I had to know was the urethra, something a little bit about the vagina, but really just the urethra. As gynecologists, they predominantly have to know the vagina, a little bit about the urethra. Everything else is kind of just there. And that's how we break it down. And so, because I have this training, this unique training where I have to know all the pelvis and I have to know how all parts work in the pelvis and how it all functions. And I'm also the one defining parts of the pelvis as well actively. It's interesting because certain conditions we've been blaming on the bladder. So I'm a big believer that conditions like IC, painful bladder syndrome, recurrent UTIs for people that have just normal anatomy, no history of kidney stones or you're like duplicated ureters or anything abnormal, I'm a big believer that it's mostly the vulva, but because we as doctors don't learn about sexual health, which is actually vulvar health, what female sexual health, most doctors don't know this. I actually teach a lot of gynecologists about the vulva and vulvar disease and vulvar anatomy, right? And we're still defining vulvar anatomy and how it works today. And so there's these huge gaps in
Mm,
care delivery, in education, and in training. I think it's doing us a disservice that urologists are leaving training without understanding all of the vulva. I think we're doing a disservice that all doctors are leaving training without understanding of the vulva.
mm,
And so that's actually why I spend so much time linking vulvar health to disease, because when I start talking about the vulva, you can almost kind of see people's face glaze because they don't really care about women's sexual health. That's a general consensus still in medicine, but they care about the bladder. I can get a room full of urologists to care about the bladder. Probably can get that same room full of urologists to care about women's orgasms, but they really care about the bladder. And so that's actually been my superpower. And it's interesting because that's also for a lot of patients too. I'll have women come in for UTIs and I'll talk to them about how important their vulva is, health is, and they're like, well, doctor, I'm not having sex, so it doesn't even matter. And I was like, okay. And I use this analogy all the time. If I were to tell you that if you were to put on this lotion onto your foot, onto your leg, it would prevent your leg from becoming red, raw, infected, shriveled, all the things. And you would do that, right? And every patient's like, absolutely. And I was like, okay, that's what's happening to your vulva right now. And I know you're not having sex and you're probably not a marathon runner. They're always like, no, I don't run marathons, but you still want to keep your foot healthy and your legs healthy. Why not the same for your vulva? And I have to always bring it back to disease for a lot of people because they're like, if you're older and you're not sexually active, you kind of are like, I don't really need to check it. I don't really need to do anything. And I'm like, no, 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 you do. You absolutely do, because we want to prevent all these things down the road. When I give them that incentive, they're like, oh, I'm on board. Sex, whatever. Bladder, though, I care a lot about that. I walk the line between the bladder and sexual health. And I'm trying to marry the two so I can get more buy-in from the medical community at large.
it seems like it's such a missing piece of the puzzle, bringing vulvar
Mhm.
health into everything, bringing it into urinary care, bringing it into gynecological care. I spoke to a pelvic floor specialist just last week, bringing it into pelvic floor care. I mean, it really is
Yes,
fundamental to our overall health and well-being. And so
yes,
many people are missing these interconnections. Um,
yes.
you talk about HMV, right? How is that different, or does it fall into the constellation of symptoms of genitourinary syndrome of menopause?
Mhm.
And can you
Yeah.
differentiate the two, or
Yeah, yeah,
clarify that,
absolutely.
please?
Absolutely. This is the frustrating thing for patients, I'm assuming, that there's just too many names. It's just like, y'all, it burns down there. That's really what they're trying to tell me. But so let's back it up. So when I think about GSM, genitourinary syndrome of menopause, a syndrome means multiple symptoms and multiple presentations. So, genital urinary syndrome of menopause is kind of the umbrella term that HMV falls into. They're kind of the
Mm,
same thing in my mind, but when people think about HMV, they predominantly think about pain with sex. And so GSM and HMV are technically the same thing. They're truly technically the same thing, but HMV is known, vestibulodynia is known in the chronic pain world. GSM is known outside of the chronic pain world, but they're literally the same. They're the same thing
okay,
in my head.
got it. And you mentioned painful sex, and I want, there's a myth out there that I want you to bust, and that is that sex has to be painful when you reach
Oh,
midlife. I had on the podcast last month Dr. Maria Sophocles, a gynecologist with a sexual
mhm.
health specialty, who spoke about how vaginal dryness is a major contributor to what she calls the bedroom gap. And sadly, I
Mhm.
hear so many women turning away from intimacy altogether. There's like this resignation and acceptance that, okay, it's just not for me anymore because I'm in midlife. But the
Yeah.
reality is, I'm hearing you say that we are experiencing so many changes between our legs as we move through
Yeah.
menopause, but there's so little awareness of this. And so, can you walk us
Yeah.
through exactly what is happening and why does vulval health matter so much?
Yes. Okay. So let's talk about this because I am a big believer in preventative medicine. And I'm also a big believer that you can have the same vulva at 20 at 100 years old if
Yay!
you
I like that.
just learned about your vulvar health and how to keep it healthy. And I'll give several things. So, like again, I said the vulva is a garden. If you do not water your garden, you cannot expect cucumbers this season,
Mhm.
right? And also, the beauty of the vulva is that once you give it the nutrients that it needs, your garden will come back. And it is truly miraculous and fascinating. So, the things that keep the vulva healthy, again, estrogen and testosterone are both vital hormones for vulvar health. And that is the thing that want everyone to know about. Vaginal estrogen is important, but it is one part of the equation. And we really got to start amplifying that message because without these specific hormones, what happens is that your tissue changes, your labia start to disappear without estrogen. Your vaginal opening actually start close up. So now your urethra, which is the hole that you pee out of, and your vagina, which had a nice healthy distance prior to menopause, perimenopause, are now right on top of each other. This change is important because also the good bacteria that was previously there that used to keep your vagina very acidic, that needs hormones to stay alive, die out. Without your vagina being acidic, that now means that all this bad bacteria can now come and colonize your vagina. And now that your vagina and your bladder are right on top of each other, this actually does predispose you to getting more infections. Other things is that skin changing, that thinning, the inflammation that happens, the dryness that happens, because now the glands that were lubricating and give you that wet feelings, they don't have any water anymore, right? They don't have nutrients to fill them up. And so no longer are they able to do those things. And so that's why a lot of perimenopausal, menopausal, postmenopausal people will develop UTIs or UTI like symptoms, pain with sex, or difficulty with arousal because you also hormones are also needed to for blood flow. When we decrease the hormones, we decrease the blood flow, which also leads to decreased sensation. And also, all of this could be prevented. Like that's the beauty of this is that it is all preventable with low dose vaginal hormones. And this is where it gets a little tricky, right? Is that just looking at the lens, currently vaginal estrogen is the easiest thing on the market right now. It's more affordable and it's getting more affordable day in and day out through advocacy. But the only medication on the market that also has vaginal DHEA which is then broken down to estrogen and testosterone in the body, is Intrarosa, which is
Mhm.
prescription based, but it's not necessarily the most cost effective. And so that's the challenging part now is that, okay, now that I know that this tissue also needs testosterone and vaginal DHEA is a great option for that, how do we then get it to people that may be not able to afford it? And so that's the conundrum that we're facing. There's some really cool companies coming down the pipeline that are trying to solve for this problem. Uloko Health is one of them that I'm very excited for. And also, this is just the reality.
So
If
you're
we
telling me
cut
that we need both. We need vaginal estrogen and we need testosterone. So because I know that
yeah.
vaginal estrogen helps rebuild the integrity of the tissue, helps with
Mhm.
lubrication, helps
Mhm.
eliminate that dryness, burning, can help with pain. I stop there with vaginal. I mean, I have a whole vulvovaginal healthcare regime, which includes vaginal estrogen,
Yes.
moisturizing lube, and that's a lot. But now you're telling me I also have to add testosterone. What is the testosterone going to do? What is that going to add?
Yes. So testosterone is needed for blood flow It's needed for lubrication. It's needed also for structural integrity. I'll go a little nerdier with you is that so the ovaries, when you go through menopause, stop producing estrogen. There's just no estrogen left in the body. The interesting thing is there's still testosterone production, and testosterone production in women is actually much higher. It's 3 to 10 times much
Mhm.
higher than estrogen. So it's a very important hormone for everyone. But when you go through menopause, you'll actually still have a little bit of testosterone. And so for some people, that testosterone is enough where vaginal estrogen alone, because it's that equation. If your body's still making enough testosterone where it's coating your tissues, you then just need estrogen, vaginal estrogen. So that's great. But I have a lot of people that come to see me that have failed vaginal estrogen alone, and that's when I am like, okay, then that's telling me that you also need testosterone in the body. So then
Mm.
we'll start treating that. And it's important to know who needs what, and the patients are the only ones that are going to be able to tell you. And so that's why I strongly recommend that all people, women, all people with vulvas start looking at their vulvas. If you start seeing changes while you're on vaginal estrogen, or you're not noticing improvement and you've been on the medication like you should be, that's an indicator that you also need vaginal testosterone to the tissues as well. You can actually see those changes. The tissue almost becomes hard and hardened and like woody like and more
Mm.
dryness, all the things. So yeah,
That, yeah,
it's
that was going to be my question to you. I love that you're advocating for women to self-check, to look, because I know there's
yes,
a lot of resistance there with some of the women that I talk to. Like, I can't look, I don't want to look. There's so much. That's a big
nice.
step. That's a big step. So
Yes.
I'm a big advocate for taking out the mirror. Yeah, doing a little bit of breath work, meeting yourself with reverence and awe and wonder of this amazing part of your body, right? Because it is
Yes.
amazing. You're making it seem like it's so integral to our overall health and well-being.
Yes,
But
it
what are
is.
when we get to that point, okay, we've broken through the resistance, we're there with our vulvas and the mirror.
Mhm.
What are some of the things we should be looking out for when we look at our vulvas in terms of changes? So you mentioned that kind of woody like color. What else?
Yeah, so knowing the parts is important.
Yeah.
So the clit, yeah, that's the first part. Get familiar with the parts, right? And also celebrate that all vulvas are different. There's
Yeah.
no normal for vulvas. Your normal is normal. And so some people will come to me years after menopause and I'll show them the changes that have, like, I assume have happened, but I don't know. I don't know their lives. I don't, this is my first time meeting you. I don't know what your vulva looked like 20 years ago from today. Only you can know that. And so that's why I strongly encourage people to start getting in touch with their vulvas. Know what your clitoris looks like. Your clitoris actually changes with your testosterone. So testosterone is also important for your clitoral health. If you're noticing that your clitoris is shrinking, if you notice that you can't pull back the foreskin of the clitoris, this is one thing I train people a lot on, is pulling back the foreskin and actually taking a look at the clitoris. There's a lot of dead skin that can get trapped in there and cause irritation, and you can actually get something called clitoral pearl, which is truly skin that is trapped and becomes hardened and keratinized like an actual pearl. And that's just living under there. And a lot of people never even notice that. So look at the clitoris, look at the health of the size of the clitoris, notice if your clitoris is shrinking, notice if the clitoral hygiene, the labia, now the inner labia, the labia minora. So your labia minora, in theory, it's a diamond and it should go all the way down to the bottom of the diamond. Not everyone, but that's just what I anticipate to see. And also, I know that as people start losing estrogen or have been on medications that change their hormones, especially if they're on those medications early in their development, their sexual development, like right around puberty, it actually changes the length of their labia. And that's okay, right? Just know what your labia look like. And then start noticing if your labia starts shrinking. So your labia will literally, what we call labial resorption, they'll literally start disappearing. So your curtains, your labia serve as curtains for your urethra. Your curtains are now disappearing and exposing your urethra, which exposes it to infections potentially.
Mm.
Other things too is when you spread your labia apart, look at the health of the tissue. That tissue that's the vestibule tissue Most people think that's the vagina, but that's actually the vestibule. That tissue should be nice and healthy and pink. And if it's not, another reason to go to the doctor. If you touch that tissue and it hurts, go to the doctor. Though none of those things are normal. It should be healthy, pink, and not painful. So those are kind of just like big things that people should be looking out for in their changing of their vulva that we can prevent. The beauty of this all is a lot of this is preventable and some of it is reversible. So if you're someone that hasn't had appropriate vulvar care, whether with your doctor, you can advocate for yourself to get you right back on track. Because again, like a garden, you start giving it water and
Mm-hmm.
nutrients, they'll
Mm-hmm.
come right
Mm-hmm.
back. Some parts though might not. And so that's if we can prevent this early, starting right at perimenopause, that's my goal. It's like you get a mammogram, you get your colonoscopy, and you get your vaginal hormones for your vaginal care because it's ultimately your bladder care down the road too.
Yeah, I'm often surprised, and this was my case too, right? Hearing you talk, that doctors who do give out vaginal estrogen will give it out without doing a vaginal health check, right? When there could
Mm-hmm.
be other things going
Yep.
on.
Yeah.
So I think, can we advocate for a vaginal health check? Say, can you please look at my vulva before you prescribe anything? Because I think there may be something else going on. I looked and I noticed X, Y, and Z. So can you please check? Who can we approach?
Uh,
Is it a gynecologist? Will a urologist do that? Who do we go to give us a
uh,
good vaginal
this
health check
is
to make sure everything is okay?
this is the challenging part is that where are the doctors that are doing this? There are some really amazing gynecologists, some really amazing urologists that do have this training and do understand, and primary care providers, a lot of ISHWISH organizers or people that are in ISHWISH and involved and go to the training and go to the courses. It was just about, I think the registry was like close to like roughly 350, 400 doctors in the United States. But there's so many people. There's like like so many more people. And so this is where, so first and foremost, to answer that first question, go to an ISHWISH provider, someone that has done the training, cares and values this work to stay up on it and do the thing. So that's really where you start. And also, this is where I need women, people that care about women, people with vulvas, and all the people to really start pushing the healthcare system and advocating for change in training. The fact that many doctors that are operating in the pelvis don't know how to examine a vulva is concerning. The fact that medical students are coming out of medical education training without understanding not only the parts of the vulva, but how it works and how it can lead to disease is concerning. Every doctor should know this. Every person that is seeing patients should know that. And so I can't say that you should go to your gynecologist or urologist that you'll get that vulvar check because they don't even, most of them don't even know what they're looking for. And
Mm,
that's the reality of the situation. And in order to start filling in these huge care gap deliveries, like I'm one of the handful of urologists that has this training, and we've been so vocal. We never stop talking. You know, Kelly Casperson has a whole podcast on menopause, Rachel Rubin, Ashley Winter. We're out here trying to speak up and kind of start, we're kind of canaries in the coal mine of being like, wait, why do we know this? And why does no one else know this? How did we not get this training?
mm,
And so this will require not only physicians buying in, but patients also advocating for this. And that's actually why I created my company, Vulva AI, around this conundrum of there are, I want to say 156 million, there's 3 billion vulvas over 18. Only so many people know how to take care of it.
mhm.
How are we going to bridge that gap in today's world?
Yeah, and I'd love to talk to you about Vulva AI in a minute. But just listening to you speak, it reminds me of this. I don't know if you've seen it, that video that Halle Berry, the
Hmm.
actress Halle Berry,
Yeah,
bravely sharing her story about her doctor, and she has access to the best doctors, right, in the
exactly.
country. And this
Exactly.
doctor confused her symptoms of genital urinary syndrome of menopause with, I think, genital herpes, which,
Yes.
sexually transmitted disease, which must have been
Yes.
so shocking. Not to mention, maybe there was some inherent racial bias in that diagnosis. But yeah, it's crazy that doctors aren't learning more about vulvar health and getting women the healthcare they need. And makes
Yes.
me think, like, how do we access this kind of healthcare? And I think, yeah, it all starts with us advocating for ourselves, knowing our anatomy, as you say.
Mhm.
That's so, so important. Let's start by knowing ourselves because, as you say, not all doctors have this information. And so knowing what our baseline is in terms of like, what are we seeing in the mirror, and then talking to our doctors about that, and going and getting second opinions, going to see all the specialists we need until we get the answers that
Yeah.
we get to solve this issue. And I'm going to put in the show notes the website address to Ishwish, which is
Mhm.
you spelled it out, the
Yeah,
International
yeah.
Society of Sexual Health.
The study
Yeah.
of women's sexual health. Yes.
So
Yeah,
so
yeah.
so women listening can find a specialist in sexual health and have them find someone who's more targeted with this. So, so important, because it's just crazy that we are where we are now, and there's just not enough knowledge, research,
Yes.
doctors with this knowledge. So thank you so much for you and what all your colleagues are doing. I love Dr. Cuthbertson, Dr. Rachel Rubin, you, Ashley Winter. I follow them closely. I love what all of you are doing to really raise awareness and really be loud about this issue, because it's so, so important. It's just crazy that we're not doing right by women. I
Yeah.
wanted just to take a couple of steps back in terms of the solutions of estrogen and testosterone. What are the delivery systems? Can you just walk us through briefly the delivery systems of estrogen and testosterone so women know what they can go in and ask for?
Yeah, so for vaginal, so this is again, we break it down into two types of things, systemic and local. So systemic is that's the like HRT. So that's what's going to raise your blood levels of hormones. So we're not talking about that. We're talking about just local hormones. There have been so many studies showing that it is safe. There's very minimal crossover into the bloodstream. We can even give it to people actively being treated for breast cancer or other gynecologic cancers, right? So estrogen, and that's the research around estrogen. Our research around testosterone isn't great because no one's doing it right now. We're working on it. My research team and I are working on it, but we need more. So, in terms of vaginal estrogen, there are options for tablets, there are options for creams that you place into the vagina, suppositories. There is also something called a little flexible ring that you actually just place into the vagina that just sits in place, and you change it out monthly or every 3 months, depending on the strength or concentration. And then for vaginal testosterone, the only thing that is currently FDA approved on the market is intrarosa or prosterone, which is vaginal DHEA, which is a suppository that goes into the vagina and you place it in there nightly. Or you can do nightly. I tell people to work up to what feels good for them. This is the thing about hormones. Hormones are individual to everyone. So I tell people to figure out what is the best for you. And yeah, those are the delivery mechanisms for the medication.
So you would recommend, if you go to your doctor to ask for one of those forms of vaginal estrogen and the intrarosa?
Either or. So again, that's why I like Intrarosa because I get estrogen and testosterone all in one. But if you, let's say, like, if your doctor doesn't feel comfortable prescribing, they shouldn't. One, if they don't feel comfortable prescribing Intrarosa, like, that's your right to get it. You should not allow for that. But if they're just like, fine, I'll do vaginal estrogen, I tell people try it, see if it works for you. Because again, you're still making low levels of testosterone in the body. So you may just need estrogen and that estrogen alone. So if your symptoms are getting better and you're noticing your tissue quality improving and staying healthy, then vaginal estrogen is just for you. But if you're noticing that your symptoms aren't getting better or you're noticing changes in your tissue quality, then I would then ramp up to Intrarosa. And
Intrarosa.
like I said, there's a over-the-counter option that's coming down the pipeline by a company called Oko Health that I'm so excited about. And so that's going to be coming fairly soon to market. So there are options. We're trying to figure out how we can get people the right care at affordable prices.
Okay, thanks for clarifying that. And then another clarification: systemic estrogen and
Mhm.
systemic testosterone? Because I know there's a lot of talk now of testosterone for brain health, for muscle health,
Mhm.
as well as
Yeah. Yeah.
sexual health and libido. If you're using systemic, so like the patch or the cream of either one of those hormones, will those help your vulval vaginal health, or you need the localized version?
So I typically tell people they'll need both. And oftentimes, the way I do monitored hormone replacement. And I take that principle from what we do in men, right? We never just start men on hormones and say, good luck, have fun. It's just like one of the most dangerous things, and in my opinion. And so I do monitored hormone replacement therapy, and I have very set goals for my patients of what's safe and what isn't. Each number, like, as long as they're within the parameters of safety, it's great, amazing. That's truly why I do it. I check for efficacy and I also check for safety. Oftentimes when I do because of that, oftentimes it's not enough to coat the vaginal tissue. And so they'll also need some form of low dose vaginal option. And the other thing too that I always like to tell people is that you might get off of HRT, like the systemic HRT at some point. Circumstances happen at some point, maybe if you reach a certain age and you're like, the guidelines say I shouldn't be on this, even though the guidelines actually say this shared decision making should take place. And you can have that conversation with your doctor if you're still having symptoms or you want to. And I'm a big believer in that because we don't take away hormones from men, but make your own decisions once you have all the right information. But the one decision I strongly recommend is you should never stop taking your vaginal hormones. You should be buried with your tube of vaginal estrogen or your intrarosa. Like, do not let people take you off of your vaginal hormones, because what you are letting them do is start a slippery slope into a world of potentially of UTIs, misdiagnosis, pain, sexual dysfunction that we could have completely avoided. So,
And regardless of whether or not you are sexually active, right? Because
exactly.
I hear women
Exactly.
say, well, I'm not sexually active. I don't have a partner, so I don't need to worry about that.
Yep, that's that foot analogy, right? It's that leg analogy. You wouldn't let even if you're not a marathon runner, you wouldn't let your legs shrivel up, become red, raw, painful, chronically infected if you knew that there was a simple cream to prevent that. And so I'm like, you wouldn't let your legs shrivel up. Why are you going to let your vulva go through all of these changes that are going to potentially harm you and hurt you? And they're like, "Oh my gosh, I didn't even think about that," because no one tells you about it. Because when we think about the vulva, we just think about sex. And sex is very important. Sex isn't important for a lot of people. And so you got to meet them where they are. And so for some people, talking to them about, you might not want to have sex, but I'm sure you probably don't want UTIs. And that gets them on board.
So our vulval health is important for our health and longevity. I know I
Yeah.
have my aunt who's in her early 90s. Bless her. She's in great health, but she
Mhm.
had an incident where she had an issue with a UTI, and she had some
Yes.
kind of mental issue, right? She kind of lost
Mhm.
her memory for a moment. She was speaking, saying
Yeah.
strange things because it was already the infection was gets to that point where you just kind of almost lose your mind for
Yeah.
it. And then they
Yes.
had to hospitalize her. It was, I mean, she's
Yes.
luckily fine now, but those things happen, and
Mhm.
they can happen all through the lifespan.
Yes, it is one of the most devastating things to watch an older woman go through the cycle of recurrent UTIs. And then it starts escalating, right? Because the more antibiotics you get, the more antibiotic resistance that you have. And so less and less antibiotics are working for you. And people literally die from this because there's no antibiotics left to treat them by the end, And it's like this could have all been prevented if we understood your vulvar health. There's definitely certain things and anatomy that make this more challenging. But for the common average person that has never seen a urologist before because they've never needed it, if your primary care provider could have just provided you with that medication for vaginal hormones at age 40, we could prevent that fate for so many people.
So it's a tube of vaginal estrogen on every bathroom
Yeah,
counter,
yes, yes,
please.
yes,
For life.
yes,
You're saying it's for life.
for life. Yeah,
Yeah.
because you would never stop watering your garden. You would
Mm.
never stop watering your garden.
Thank you. I love that. I love that analogy. Okay, I want to switch gears here now because I can't let you go without addressing your enormous contribution to our understanding of human sexuality, in that you were one of the scientists in the groundbreaking study of the human clitoris, which this was just recent, right?
Yes.
2023. So this groundbreaking study into the human clitoris, which correctly identified that the clitoris has 10,000 nerve endings, not the 8,000 that was being quoted for years and years, and that actually was being referenced, was actually those 8,000 nerve
From a
endings
cow.
were from a cow. And I don't know how we got
Mhm.
there. Can you please tell me, how did we get to thinking that they had the same clitoris as a cow? And what does this mean for the future of, yeah, our sexuality,
Yeah.
understanding it to this level?
Yeah. So, I think this study really speaks to just the level of attention and care that is paid to science when it comes to women. So 8,000 nerves, that what came from a cow study. Jessica Pinn was the person that actually put two and two together. But I think it speaks to that larger narrative of what I saw. There's not a lot of research in women. It and this lack of research and this lack of scientific rigidity and standard is not translated into the field of women's sexuality and women's sexual health. And I think being part of this fellowship that I was part of, we are forcing that narrative or changing that narrative. Ishwish is changing that narrative where we're bringing science to women's sexual health and to women. And if we look at the huge research gap between men and women, is so big sometimes that it just like overwhelms me and like I just want to like double over. And so that's really what I think this study speaks to, is that in 2023 we finally defined how many nerves are in the human clitoris, even though we've been operating on the clitoris and causing injury to the clitoris for decades now, right? And yet we just didn't know, and no one really thought to do this study or do this work. And so what I love to do is unbust myths and bring more scientific integrity into women's health, because the lack of scientific integrity, the fact that most doctors don't even know that the ovaries produce way more testosterone and a lot of the medications that we give are anti-testosterone, which then cause all these issues downstream, that's anti-science. That is often what I see happen in women. There's a lot of feelings over facts. And I want someone that wants to bring the facts plus the feelings. I think feelings plus facts is a beautiful thing, but a lot of the times the feelings are rooted in either misinformation or rooted in kind of this ingrained misogyny or medical sexism that we continue to perpetuate. Like I up until 2020, I would be like, I'm one of the biggest feminists. I think everyone should have equal access to healthcare. And then I did my fellowship and I was like, oh my God, I was just as big of a problem. And I didn't even realize it. And I want to raise the consciousness of all doctors to start saying, wait a second, why have we been doing things the way that we've been doing? Or why do I believe that? And actually start going to the literature and start asking clinical questions and start doing their own research. And actually, like the amount of women that have been told, don't take hormones because it's dangerous. What study is that? There's been so many studies that show that it's actually really safe, but most doctors aren't doing their due diligence to stay up on the research. So
Mhm.
research isn't being done, it's not being funded, and then doctors don't then do the work to do the research. And this is just a story that I see time and time again. And the only people that are suffering are the patients, because they're the ones that are being told, oh, that condition that you have, never heard of it, probably in your head. There's no treatment for it. And then they come to see me. I'm like, there's absolutely a treatment for it. It's absolutely a thing. And we can fix you. Like, we can heal you. And I think of research as advocacy. And I think this
Mm.
clitoral study was our first bit of correcting a lot of the misinformation and adding to the literature that is doing that work. Because I'm not the only scientist. There are so many scientists I've seen on the shoulders of giants. And a lot of my scientific work also comes from them laying down the groundwork for me. So I'm just a small player in the cog,
Oh,
but
well, no, thank you. Thank you so much for literally, you're putting the clitoris on the vulval roadmap. We've ignored the vulva, and much worse, we've ignored the clitoris. I had on the podcast, very first podcast episode, Sherry Winston, who's a holistic sexuality educator. She wrote this book called The Women's Anatomy of Arousal. And she pointed to, scientific literature where it was erased, right? It once was in the literature, but then it was erased and
yep.
ignored for so long. And I think by understanding the clitoris and the way you've brought it to light and how amazing it is, I think we can now hopefully focus on accessing the immense amount of pleasure that exists there.
Mhm.
And so
Mhm.
understanding the whole clitoris, not just the little, because I mean, all those nerves don't exist just in that little tip head of the
Exactly.
clitoris. There's a whole amazing structure, which if people go back to listen to that episode, I think it's episode number 4 with Sherry Winston, she talks us through all of the anatomy of the clitoris and how to spend time. It takes time, taking time to get to know the clitoris and how to access the different zones of pleasure. And we
Yes.
often we often don't do that. Take the time to do that, and
Yes.
we try to take a quick, fast approach. I've talked to experts here, and I'd love to get your take on it. I know that you advocate for the use of tools and toys like vibrators, but what some of the experts have said to me, have said on the show, is that those tools are great for getting you the quick fix if you want that, but they
Mhm.
bypass this beautiful understanding of the clitoris because you can use that vibrator to access all the different points along the clitoris structure and just use it to just build arousal and then notice, just we ignore all the incredible sensations that the clitoris has to offer us by just going for the straight kind of buzz kind of
Right on top. Yeah.
orgasm, which is great. But so using it as a tool to get to know your clitoris, like, if I touch there, this is what the sensation it gives, or if I touch here, this is what it does, and to allow for that slow buildup of arousal, that slow buildup of engorgement, which just leads to mind blowing pleasure. I think.
Yeah. Yes. 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 I think it speaks to time, right? Time and knowing your body. Another reason why knowing your body, you can prevent disease and you can have better orgasms. So, um, y'all start knowing your body, start exploring your bodies. It is so
And,
important. I am giving you permission. Not that I need to, right? But I feel like a lot of people it's so fun to like literally watch the shackles of society come off when I'm able to talk about sex through a scientific lens of just yeah, it's just science. We're talking
yeah.
science, no shame, pure science.
Thank
And
you.
it
Thank you so much for doing that with this incredible study. I think that we're going to hopefully see things shift by putting the clitoris on the vulval roadmap again. Finally, I want to talk to you about your exciting new initiative. You founded this incredible new tech initiative called Vulva AI, which I feel is going to revolutionize female sexual health through education, advocacy, and technology. Can you tell us why Vulva AI? How does it work and why now?
Yes. So, why vulva AI? So, if you're someone that's suffering from recurrent UTIs, chronic pelvic pain, recurrent vaginal infections, IC painful bladder syndrome, this is for you. And one of the things that I constantly saw was the same stories of doctors don't know, patients don't know their own anatomy, doctors don't know patients' anatomy, and then patients don't have resources to go to. And it was so frustrating to hear and see, a patient that I could, for most chronic pelvic pain, I'm a big believer that things like chronic pelvic pain, recurrent UTIs, for the most part, is actually misdiagnosis. There are definitely people that truly have recurrent UTIs, and there are definitely people that truly have chronic pelvic pain. But a lot of people actually fall into this category where they're just being misdiagnosed and given the wrong treatment. And so I can diagnose someone in 20, 30 minutes that has spent their last 30 years trying to find a doctor that even knows. But now the hard part for me is now I have to unpack 30 years of their trauma, 30 years of their disease worsening, 30 years of the psychological turmoil that it's come on to this that's worsened their disease as well. And now I have to deal with that. And we have to deal with that together as the patient and doctor. And knowing full well that if this person had come to me 30 years ago, I was two and in Nigeria, we could have fixed this so much sooner. And then also seeing how hard I was working to try to educate doctors. I was at a conference every month, one or two conferences a month for 2 years, trying to teach doctors. And I realized that the same doctors were coming to these meetings, when in actuality, I need every single doctor to know this. And so I saw this, and I have a lot of friends in tech, and I see the writing on the wall. I see that, what tech is meant to do, doesn't always do this, is that it's able to disseminate and scale care or solutions broader. And so it's like, I have all this knowledge, I have all these tools, I know how to diagnose people. Why don't I just teach that to patients and teach them how to diagnose themselves? And so that now when that patient goes to the doctor, they now know, hey, doc, I've been having XYZ symptom. I think it could be hormonally mediated vestibulodynia and pudendal neuralgia. These are the labs I want to order. And this is how we do it. I already did my own exam because a lot of the vulvar exam is all external. Rarely ever have to use a speculum for patients, and you can see everything and actually guide you through that process. It's like having your own vulvar specialist in your pocket. And so that you can now, when you go to the doctor, there's no more gaslighting. You are actually just as important as the doctor themselves. And you probably will know more than the doctor themselves. That's the unfortunate part. But that's the reality. And I have to start seeking that honestly. But you are now able to advocate for yourself and get better, cheaper, faster diagnosis. It takes 7 to 10 years to get a diagnosis for chronic pelvic pain. It takes at least 3 doctors to get first diagnosis. And for some people, 35% of people will see more than 15 doctors to get the right diagnosis. I can't live with those stats, right? Like, it's just, I had a year and a half waiting list, and I was like so burnt out, so this, that, and the other, everywhere, pulled in so many directions, trying to fix this problem. And I had to step back from my clinical work to go and build this company, because it's like, I can't train every doctor because every doctor doesn't care, but I can train every person that has this to figure out ways to get their health care. And we're in talks of partnering with institutions too now, so that potentially the burden doesn't have to be on the patient to do this. But I saw the problem. I saw that unfortunately patients with these conditions are already leading the charge in their healthcare. They just didn't have the right resources, because a lot of what you find on Google is wrong, to then make right decisions in the healthcare field. So I wanted to be able, when I say it's a love letter to my patients, it's a love letter to, all women, to all people that care about
Mm.
women. People with vulvas, the rate of medical gaslighting is 76% in women. And I want women to start trusting themselves more, knowing their bodies more, knowing the science behind their bodies more, because the healthcare system isn't doing that. And until we start holding them accountable, we have to do it ourselves. And so I want both things to happen simultaneously, because I want this also to kind of be this rallying cry for women. One thing I've noticed is the importance of stories. So we actually have this campaign where we're going to start collecting stories. I've sat with over 2,000 women and people with vulvas and heard their stories of medical neglect, misdiagnosis, abuse, malpractice, like truly some of the worst stories. And I those stories affected me, and to the point where I left and started a company around it. And I think if more doctors were privy to these stories, to understand what our ignorance is doing to people, it's forcing them to have these stories. That's going to be so, so, so much more powerful, because ultimately this needs to go all the way up to Congress. This needs to be policy change, insurance change. Like in my clinic, I couldn't even bill correctly for certain conditions. I had to go find CPT codes that were close to it, right? Like that's how bad, like some of the diagnoses don't even exist for billing. Like essentially insurance companies are saying your condition that is very real doesn't matter to us. So this is where we're at, right? And it's such a big problem that a lot of people want to say, thank you so much for saving me. And I'm like, no, no, no. I need you in this fight with me too.
Yes.
Because it's not just me. It's not just going to be the urologists that are loud and out there and our gynecology colleagues. Like we need to be supporting our gynecologists. It is unfair that gynecology has been given the responsibility of taking care of all of women's health when they're only trained to take care of a small part of it. And all of us collectively as physicians need to step up and start supporting our gynecology colleagues and supporting women. And I hope one way to do that is through Vulva AI.
Thank you. Thank you so much for putting our vulvas back on the medical maps and for literally giving us the tools so that we can take our vulval health and our sexual pleasure into our own hands, really
Yeah.
at the tip of our finger. So thank you so much. I can't wait to see what transpires with the emergence of this incredible new technology. Congratulations. Thank you. Thank you. And if there's anything that I or our listeners can do to help you move this mission forward, please do let me know. We'll do a big shout
Yeah.
out and make sure. I know you're looking for
Yeah.
some funding.
Yeah.
So, we'll do a big shout out for funding, whatever is necessary, because I am with you, Dr. Uloko. This is so important for our overall health, well-being, and longevity and pleasure. So thank
Yes.
you so much for being here. Tell us how we can find you, where we can find you.
Yes, so you can find me on social media platforms. My Instagram handle is Maria Uloko MD. I drop office hours with Dr. Uloko. I love teaching, so you'll learn a lot of things about your vulvar health and also your penis health because I do them all. See, I'm also on TikTok, Sex Med
Okay.
Ed. You can also follow Vulva AI, sign up for the mailing list. Any and all signups matter and is really helpful, especially in the fundraising process. You can also follow vulvaai.co. It's vulvaai.co, so vulvai.co on all platforms, TikTok, Instagram. You could follow me on Twitter, Maria Uloko, and I'm opening up my in-person Beverly Hills practice July 1st. So if anyone wants to come, it's in California, or want to fly out to California and come see me and work with me and optimize your urinary, vulvar, sexual health, penile health, all the things. I'd love to work with you.
You
So
do any
yeah,
work on online telehealth?
I'm shifting from telehealth to in person, but I'm still going to do a one-on-one consultation telehealth. So those are for people that live outside of the state of California, because I'm only allowed to prescribe in California, but do want medical guidance, right? It's essentially like a second opinion on whatever sexual health concern that they have. I am really good at figuring out like I'm a sexual health Sherlock of figuring out what's going on, how to treat, and then I walk you through how to advocate in the doctor's office, what testing you should be asking for, and then what the recommended treatment is. And so following along with you from there.
Wow, what a gift you are. Thank you so much for everything that you're doing to contribute to the space of sexual health and wellness for women. Thank you for being
Of
here,
course.
Dr. Uloko.
Thank you for having me.
Such a
Thank you.
pleasure.
Thank you.
I hope you enjoyed this episode of Pleasure in the Pause. Want to help me spread more pleasure in the world? Hit the share episode button and send it to a friend, or post it on your Instagram stories and tag me, Gabriella Espinosa. And if you really love this podcast, please leave a rating or review, as this helps the show get in front of new listeners. Finally, if you would like to access even more pleasure and stay in touch, sign up for my free pleasure upgrade bundle of powerful mind-body practices by going to pleasureinthepause.com. Remember, your pleasure matters.